Good afternoon, everybody. Thanks to the organizer for inviting me and Dr. Bertini to introduce me. So today I will talk about mitochondrial leukoencephalopathy, a topic of interest of mitochondrial researchers. As a clinician, I would like to share the result of our study integrating the clinical, radiological, and molecular data with aim to improve knowledge and clinical practice in this field. So, why do mitochondrial dysfunction lead to white matter damage? We know that mitochondrial functions are essential for whole subtype cell of white matter, for neuronal high energy demands, for oligodendrocyte differentiation and survival, for microglia activation and modulation, and for astrocytic function regulation, especially neurotransmission. So the mitochondrial function alteration in all these subtypes of cells leads to white matter tissue damage. The association between mitochondria and leukoencephalopathy was first highlighted at the late 70s. Additional reports were described 10 years later, and at the early 2000s, Kang described the first case series introducing the issue of differential diagnosis of mitochondrial leukoencephalopathy among genetic leukodystrophy. In following years, in several mitochondrial encephalopathy pediatric case series, the frequency of leukoencephalopathy was analyzed, showing a progressive increase over time. In one of the most recent case series, the percentage is lower, but this report included also adult patients. There are a few studies on frequency in adulthood. They report about 5% of prevalence of mitochondrial leukoencephalopathy, both in mitochondrial disease and the leukodystrophy case series. Today, an official classification is not available. More than 30 genes related to mitochondrial function have been identified, and their alteration leads to development of white matter tissue damage. This is the largest cohort published to date, focusing on radiological patterns, including both pediatric and adult patients. The author underlined that there are several common radiological features suggestive for mitochondrial diseases, but no genotype radiological pattern correlation was identified. Moreover, this study didn't analyze clinical findings, outcome, and phenotypic differences between pediatric and adult onset. Based on this data, we designed our study. We screened patients in Italian Register of Mitochondrial Disease in Genomit using keywords white matter lesions and T2 hyperintensity. We created a database focusing on MRI patterns related, of course, of white matter involvement. Then we contacted clinicians in order to provide missing clinical data, to report specific MRI findings, to add newly diagnosed cases, and to verify genetic diagnosis. Inclusion and exclusion criteria were verified for each patient, and a retrospective observational study, both descriptive and analytical, was then conducted. We collected several data, molecular data, clinical and radiological data, of course focusing on white matter involvement, and so white matter alteration site, type, distribution, and additional lesions apart from white matter involvement were also recorded. Then we analyzed several subgroups, and the statistical analyses were conducted for analyze and compare this group. We collected a large amount of data. Today I will share the main results. Starting from more than 200 screened patients, 94 patients were involved in the study. The reasons for exclusion were the incomplete medical and radiological data, the presence at MRI pattern of a primary gray matter involvement with minimal white matter involvement or without white matter involvement, for example, Lee syndrome, and in 5% of patients, the absence of genetic diagnosis. Due to the retrospective nature of our study, some data as radiological follow-up, spinal MRI, or survival data were not available for all patients. The 94 patients were collected from 14 different centers, both pediatric centers in red tone and adult centers in blue tone. 41 patients were collected in pediatric centers and 59 in adult centers. However, looking at age at onset, we disclosed that 60% of patients presented a childhood onset, meaning that 90% of cases with childhood onset presented either diagnostic delay or transition in adult care. Then we analyzed and compared data between these two groups. The median age at onset was 2.4 and 30 years for respectively in the two groups. Both children and adult patients presented a diagnostic delay around 9 years and a disease history duration of 30 and almost 15 years. Regarding symptoms at onset, it was interesting that in adult patients, the extraneurological manifestations were the more common presenting symptom as hearing impairment, cardiac, and respiratory involvement. Instead, development and cognitive impairment were significantly more frequent in children as manifesting symptoms. At the last follow-up, the pediatric patient presented in addition pyramidal signs. The most frequent neurological signs in adults were cerebellar signs and neuromuscular signs, but without any statistically significant difference between compared to children. The main MRI pattern was a radiological pattern was a dystrophic pattern. However, 20% of pediatric patients presented also apiomyelinating pattern. Isolated multifocal distribution of alteration of white matter was a typical pattern in adult patients. Instead, the confluent abnormalities were more frequently observed in children. The involvement of corpus callosum and the cavitated pattern was significantly more frequent in children, both at onset and the last follow-up. Subcortical involvement, especially in temporal lobe and association with the cerebellar atrophy, were more frequent in adults compared to pediatric patients, but without statistically significant difference. The treatment strategy was quite similar between these two groups, except for liver transplantation, hematopoietic stem cell transplantation, and experimental drugs in specific forms, and for thiamine prescription, which was mostly frequent in children due to the higher prevalence of PDH-related disorders in childhood. There are important differences about outcome and survival between these two groups. The adult patient presented a progressive disease with exitus in 20% of cases. Instead, patients with pediatric onset, more than half patients with pediatric onset presented an improvement of stabilization with or without intermittent worsening. And generally, we can say that patients with pediatric onset disease appear to survive longer than those with adult onset disease, with higher survival probabilities over time and the longest average survival. However, this difference didn't reach any statistical significant difference due to the small number of deaths, 13 if I remember correctly, and so it should be considered an exploratory results. Our cohort confirmed the genetic heterogeneity in mitochondrial leukoencephalopathy. We disclosed 31 genes, mainly related to nuclear DNA and mtDNA deletion. mtDNA macrodeletion and alteration of genes encoding for complex 1 were more frequently in pediatric onset. mtDNA mutation 3243 was the main reported in adult patients. The genetic findings reflect the distribution in different phenotypes of our cohort. The more common syndrome in pediatric patients was Kearns-Sayre syndrome and MELAS in adult patients. However, many patients, especially with the pediatric onset, didn't fit known mitochondrial syndromes, and we defined them as non-syndromic leukoencephalopathy. So, summarizing this part of result, we define distinct pattern, distinct pediatric and adult phenotypes with the significant differences between these two groups about clinical, radiological, genetic, and outcome data, as I have summarized in this table. In the last part of my presentation, I will share the data about this non-syndromic leukoencephalopathy group. 51 patients presented this pattern, mainly with the pediatric onset. The more common symptoms at onset for adult patients were ptosis, hearing impairment, and myopathy. And in children, cognitive involvement, hypotonia, and pyramidal signs. The MRI pattern was the MRI alterations were quite similar between these two groups, except for the more frequent involvement of corpus callosum in children. Instead, adult patients presented more frequently, but without any statistically significant difference, subcortical white matter, cerebral, and cerebellar atrophy. These are the genetic diagnoses. The most common was POLG in adult patients, DARS2 in pediatric patients, and generally the genes disclosed were related to MTR's group gene, complex 1, iron sulfur cluster pathway, and PDH. So we asked if there are any radiological features preferentially associated with the genetically defined and or potentially treatable subgroup. And so we conducted an exploratory association analysis between MRI findings and treatable or genetic subgroups using Fisher's test. We analyzed each MRI findings for each patient of each group. It was interesting that cerebellar involvement was frequent in MTR's defects and iron sulfur cluster defects, and absent in complex 1 and PDH defects with a statistically significant difference, and as well as brain stem white matter, which was frequent in patients with MTR defects and absent in other subgroups. Then we ask about any correlation between outcome and genetic pattern. The patient with better outcome were patients with complex 1, mainly with pediatric onset. In the EASE cohort, we identified 2 patients, with the pediatric onset at 1 year and 3 years of age. After a normal period, the presence of trigger was associated with the onset of disease, and then in a brief period, they developed a clinical picture, a severe clinical picture characterized by psychomotor and cognitive involvement, pyramidal signs, ataxia, severe dysphagia. And this is the MRI pattern. As you can see, a diffuse white matter involvement with cavitated pattern in both patients. After diagnosis, they started treatment with riboflavin, which was increased in time. And after a few months of treatment, both patients presented a significant clinical improvement. The first patient, after 15 months, showed only mild distal pyramidal signs, and then a mild cognitive impairment became evident, stable in time, in a total follow-up of 17 years. The second patient, after 13 months, showed a completely normal neurological examination, normal IQ, stable in time. Now he is attending university. Moreover, we disclose normalization of serum lactate pyruvate levels, and the riboflavin supplementation in cultured fibroblasts from both patients resulted in a substantial increase in complex 1 enzymatic activity. This is the radiological follow-up. As you can see at the first follow-up, about 1 year after the treatment, the lesion reduced, the cavitated pattern disappeared, and the improvement goes on in the following radiological follow-up. In the last one, as you can see, the MRI in particular of the patient number 2 is quite normal. There are some reports like this in the literature. 8 patients have been described with mitochondrial encephalopathy associated to complex 1 deficiency and riboflavin responsive. But in these cases, the follow-up ranging from 7 months to 8 years. And the radiological follow-up is not available. It's available only for 1 patient who was asymptomatic. So, summarizing the results of our study, we described the largest cohort of mitochondrial leukoencephalopathy reported to date, comprehensive of not only radiological or genetical data, but all clinical radiological and genetical data. Our results confirm the genetic heterogeneity in this kind of disease, as well as clinical radiological heterogeneity, but we can distinguish phenotypic subgroup, Kensayer, Melas, Minge, and MERF as well-known mitochondrial syndromes, and our results confirm the clinical and radiological known patterns to date. However, a substantial proportion of patients presented with non-syndromic leukoencephalopathy, especially in pediatric onset, associated to MTHR's gene, complex 1 encoding genes, iron sulfur cluster pathway, and the PDH genes. In our cohort, 60% of patients presented pediatric onset and 40% adult onset. This underlying disclosing an increase of frequency in adult compared to previous studies. Moreover, we defined with distinct pediatric and adult phenotypes underlying significant differences about clinical, radiological, and outcome and genetic findings. There are MRI insight, except for non-syndrome. MRI genotype correlation is generally missing, but subtemporal white matter involvement appears as a diagnostic clue for cerebellar and brainstem involvement. Some cases of our cohort were treatment and particularly riboflavin responsive, underlying the importance of recognizing treatable conditions and the need for further studies on compounds' efficacy. And the design of our study, which was an integrated approach of a clinical, radiological, genetic approach, is essential for diagnosis as management of these rare disorders. Of course, our cohort was almost 100 patients, and so further study on a larger cohort could be useful to validate and integrate our results. So I want to ask all patients and family involved in this study, my colleagues of Child Neurology Unit on Besta, especially Dr. Giulio Ferrera, MD PhD student who works with me on neurometabolic disorders, all Italian colleagues of our network, and if you want to share your data or know something else about the result, you can contact me. And of course, thank you for your attention.